So, dear colleagues, dear Professor Yosefi, and dear Chairman, it's a pleasure and an honor for me to be here with you and to give you a concise summary of three-dimensional anatomy. This lecture was prepared in collaboration with Dr. Nečas and Kovalova from the Czech Republic, and hopefully I will give you a concise idea how to look in the three-dimensional space. When we start with 3D Echo, we mainly acquire a full volume data set that can be cropped in the coronal, in the sagittal, and of course in the transverse plane to look inside to the data set and to analyze the different structures. So we have to be familiar with this cropping, and later on I will show you with the slicing techniques. When we acquire those full volume transesophageal data sets, we look mainly at the base of the heart, and this is the so-called four-valve view, which consists all the four cardiac valves, and the big data set has got a degree around 100 degrees in all directions. The depth is defined during the acquisition. How to obtain the four-valve view? Mainly we start with the mid-esophageal 0-degree four-chamber view. Afterwards, we have to a little bit increase the lateral width of the data set, tilt a little bit anteriorly, and then when the data set is completed, rotate it into the anatomical orientation. If we look at the base of the heart, we can notice the mitral valve and the aortic valve in the middle. And of course, the aortic valve has got an anterior position, and the mitral valve has got a posterior position, and the tricuspid on the left, and the pulmonary in front of the page. In the middle of the center of the data set, there is the aorticomitral continuity. We do know there is really a continuity in between the posterior wall of the aortic root and the anterior mitral leaflet. The septal region, the interatrial septum, is behind the non-coronary cusp of the aortic valve. This is always a very good point of orientation. So we can see here on this data set the mitral in the surgical view. With a slight angulation, we see the aortic valve. The pulmonary valve is in front of the aortic valve. It's quite far in the far field if we perform the transesophageal approach, and that's why the image quality is a little bit compromised. So it's not that easy, and not all the patients are suitable to visualize completely the pulmonary valve, and the image quality might be a little bit compromised. However, in the majority of the cases, it's possible to visualize the pulmonary valve as well. The left atrium consists of several structures. For main orientation, we look at the left atrial appendage, which is close to the anterolateral commissure between the anterolateral commissure of the mitral valve, and the posteromedial commissure of the mitral valve is close to the atrial septum. So this is a rotated data set, and on the left side of the screen you can notice the en face orifice of the left atrial appendage close to the anterolateral commissure. It might be quite useful in case of rheumatic valve disease when we separately assess the commissures and start with the anterolateral commissure. I get back a little bit. This was the en face view of the left atrial appendage. There are a lot of anatomical variations. For example, in this case, you can see that there are two lobes and one main orifice regarding the appendage. And during interventions, for example, device closure of the appendage, the analysis, the three-dimensional analysis is quite important. I guess Professor Josefi will go into details. The left atrial appendage is close to the orifice of the left upper pulmonary vein, and mainly they are separated by a tissue ridge, the Wallace ridge or Syncoma ridge, as it is mentioned in the literature, which might be a tiny structure or might be a prominent ridge on the anterolateral wall of the left atrium. Those are different cases with the ridge separating the two orifices. The right side of the left atrium will show us the right upper and right lower pulmonary veins, and behind or beside those entrances, orifices, in the background there is the superior vena cava. So let's look at the left atrial septum, which is quite important because we produce those 3D images during the closure of the patent foramen ovale or different types of ASDs. So the posterior medial commissure of the mitral valve is close to the interatrial septum, and the central part of the septum is the fossa ovalis. It is a quite thin structure, and be aware of dropout artifacts. Sometimes it's not visible because of the thin layer of the flap in the foramen ovale and looks like a hole. The superior part of this region is close to the non-coronary cusp, the transverse sinus, and the vena cava superior. We have to understand how this interatrial septum develops in utero. First, the septum primum develops, then small holes develop in this first septum, separating the left and right part of the common atrium, and as a folding of the atrial wall, on the right side the septum secundum will develop. But in 30% of the cases, the closure between the septum secundum and primum is not 100% complete, and even in the adult, shunt can be noticed between the left and right atrium. Due to the development on this manner, we very often can observe on three-dimensional images this patent foramen ovale, and the orifice is located superior. Sometimes we can observe that the septum primum looks like different tiny bands, and not only one but several orifices of the PFO is on the screen. It might be very important when we plan a device closure of the PFO. In other cases, the overlap of the two layers form a strudel, a canal, a long canal, and with slicing methods we can measure the width and the length of this canal, and of course with cropping we can look inside the canal. With Doppler techniques, of course, we also measure the flow and the direction of the flow. The patent foramen ovale is quite important clinically because in case of increase of right atrial pressure, thrombus can pass through this patent foramen ovale as in this case, you can see an in-transit thrombus just trying to get through the interatrial septum from the right to the left. Let's talk a little bit on atrial septal defects. The secondary type defects are located in the central portion of the interatrial septum. The primum type defects are located close to the atrioventricular valves, and the sinus venosus type defect, in that case the superior, is located on the superior portion of the interatrial septum. So I will show you some typical images of ASD2 or secondary type defect, which is always in the central part of the septum. And we can look at this defect from the left and from the right side, and the three-dimensional images enables the dynamic measurements regarding the size, which is different in systole and diastole, and probably we will practice during the hands-on training how to measure accurately the diameters of these oval-shaped defects. The ASD1 is mainly associated with the abnormal development of the atrioventricular valves, and that's why we mainly see a wide cleft regarding the anterior mitral leaflet, and that's why the mitral leaflet might look like a three-leaflet structure with superior and inferior bridging leaflets and a mirror leaflet. The sinus venosus type of the EESDs are very often associated with abnormally drained pulmonary veins. So in case of ASD, we always have to check for the drainage of the pulmonary veins. Mainly the right upper pulmonary veins drains into the vena cava superior. What about the different structures of the right atrium? The tricuspid valve is visible on the four-valve view of the heart. We differentiate the septal, the anterior, and the posterior leaflets. And the posterolateral part is very important. The vena cava superior is separated from the right atrium by the crista terminalis, which is an elongated, thin muscular structure on the posterior wall. With some tilting, we can visualize this smooth surface of the posterior part of the atrial septum and the posterior part of the right atrium. And we also can visualize, this is another superior view, and we also can visualize the inferior part of this region, which is quite important in other electrophysiological ablation techniques. Right now we can see the entrance of the inferior vena cava, and with slight rotation the orifice of the coronary sinus behind the left atrium. This is another 3D zoomed image containing the orifice of the vena cava inferior, the coronary sinus, and some part of the tricuspid annulus. The coronary sinus is behind the left atrium, and the orifice is visible in the right atrium. Here you can see the coronary sinus when I tilted the probe posteriorly, and on the right side of the image, the entrance, the orifice of the coronary sinus. Why is that region important? Because we also can observe the Eustachian valve, which separates the IVC from the coronary sinus orifice. It again shows a great anatomical variation between the patients. And in between those structures, we can identify the cavo-tricuspid isthmus. And during EP ablation techniques, they cut through and ablate this region. The lateral wall, mainly the anterior part, the lateral wall exhibits a lot of trabecular muscle and sometimes muscular bands, as you could notice on this image. We can appreciate a lot of pathology in the right atrium. This was a nice case when the pacemaker lead was implanted into the right atrium, and at the contact point of the pacemaker lead and the lateral wall of the right atrium, some damage of the endocardial surface resulted in a thrombus formation. And on the image you can see quite a big thrombus, which the length was more than 10 centimeters and the width was more than 1 centimeters, and it was a highly mobile mass attached on the lateral wall of the right atrium. Let's continue with the ventricles. We have to properly select the depth of the data set to encompass the apical region of the ventricles, and we do know that the right ventricle has got an irregular shape. It is in front of the left ventricle in a crescent shape. That's why the quantification of its function is so difficult. In congenital disorders, sometimes it's quite difficult to differentiate between the valves and the ventricles, but we have to keep in mind that the ventricles keep their AV valves, which is a point for orientation. So the mitral belongs always to the left ventricle and the tricuspid to the right ventricle, and the insertion points of the tricuspid valve is shifted a little bit toward the apex. In pathological cases in Epstein anomaly, the distance is quite big, but normally it's around 8 to 10 millimeters. So this is the longitudinal section of the right ventricle and tricuspid valve, and this is the anatomical view. If we cut our data set and we crop the anterior wall of the right ventricle, we can visualize the interventricular septum anteriorly. This is how I did it first, but this data set didn't encompass the apical part of the ventricles. But with two-dimensional echo, we just always cut through one specific point of the ventricle. That's why three-dimensional echocardiography helps us really to differentiate and to diagnose the different types of ventricular septal defects, which may be perimembranosus, muscular, subarterial, or Gerbode type. So this is a better data set I could acquire. The anterior part of the right ventricle is cropped, and we look at the interventricular septum from anteriorly. The different portions of the interventricular septum are the inlet portion, the apical, which is trabeculated, and the outlet portion close to the pulmonary valve. And the different type of the defects can be located superiorly or on the muscular portion. And in between the inlet and the outlet part of the IVS, we can find the septomarginal trabeculae. One brand of this prominent trabeculae is the moderator band. So this is an animation demonstrating the location of possible locations of the different septal defects on the three-dimensional images. And this cut plane is very easy to get and to look at the different types. This is the inlet type perimembranosus ventricular septal defect. It is beneath the tricuspid septal leaflet, and we very often can observe an aneurysm of the fibrous septum. Also, the septal leaflet can be redundant and in some cases might close this tiny defect with the redundant tissue. Those are the images from different views. The shunt jets might be restrictive or non-restrictive and may lead to the dilatation of the left ventricle. This is the outlet type, which is always beneath the aortic valve and very often can cause aortic regurg. And what is the pathomechanism of the aortic regurg in those cases? During systole, the shunt jet will lift and push mainly the right or the non-coronary cusp of the aortic valve superiorly, and during diastole, the aortic root blood volume pushes back and the right coronary cusp might prolapse. Some images of this perimembranosus outlet type defect. And the muscular type of defects may very often close in the childhood. They might be multiples, and we always help the color Doppler. We use the color Doppler, of course, to identify them. The subarterial or double-committed ventricular septal defect is a rare defect, and another very rare type of this VSD is the Gerbode type defect, which will result in a shunt between the left ventricle and the right atrium. This is a tiny defect causing a high velocity jet in a very weird orientation in the right atrium. Let's deal with the valves, and I mainly will focus on the mitral and the aortic valve. The most beautiful images might be acquired on the mitral valve, and both the atrial and the ventricular surface is easily be recognized. If we cut in the coronal plane, we can produce those close-up views. This one contains only the posterior leaflet, very easy to identify the prolapsing segments. Or if we half cut the plane from the posterior part, then the anterior leaflet and the close-up view of the anterior leaflet, and behind its leaflet, the left ventricular outflow tract with the aortic valve can be demonstrated. We very often produce different static and dynamic models of the mitral valve. The TomTec and the QLab software is capable to produce the valves, and we differentiate the different scallops. Regarding the anterior leaflet, the scallops are theoretical, but in the posterior leaflet, small indentations or deep clefts can separate the three posterior scallops from each other. In case of myxomatosis valve disease, the ruptured chordae are clearly visible on the left atrial view of the valve, and it's much more easier to diagnose the different types of prolapse. On the previous image, it was a rare A3 prolapse and flail. On the next image, it's a form first. We do know that this group of diseases makes a spectrum from 1 to 2 or 6 segment prolapses. This is the form first of one patient when both the anterior and the posterior leaflets are affected. it's really an advantage of the three-dimensional real-time transesophageal echocardiography that we can rotate the data set and look en face the regurgitant orifice. We can make rough measurements on those on-glass measurements on those images, but we mainly analyze with slicing and cropping the disorder. This is a typical Barlow disease when all the 6 scallops are severely prolapsing and the posterior leaflet is quite redundant. This is another orientation when a commissural scallop is visible, and I rotated the data set and cropped half to identify the exact localization of the regurgitation. We mainly slice our data set with multiplanar reconstruction. This is one method that I show on this image, and we will practice it probably on the data set. Orthogonally fixed the cut planes, we rotate them around the center point of the leaflet, and the corresponding two-dimensional image will definitely show whether there is a prolapse or the coaptation is properly maintained. Another technique is the carousel. In that case, we fix our cutting planes on the highest anterior portion of the mitral annulus and rotate the red cut plane through the different scallops. The measurement of the intertrigonal distance might be important in case of valve repair techniques. Those are the 2 points that we would like to accurately measure during the analysis because that measurement will help the surgeon to select the proper ring size. So I show you on this animation how we align our cut planes for the accurate measurement of the intertrigonal distance, and this measurement cannot be made with the help of traditional two-dimensional echocardiography. Of course, when we analyze the pathomechanism of the different regurgitations, 3D is a big help, a great help for us, because the exact origin of the regurgitant jet can easily be appreciated. And in case of prosthesis, during the device closure of the paravalvular regurgitation, three-dimensional echocardiography is really indispensable, I think. What about the aortic valve? Again, nice images can be acquired with the rotation of the data set. We can see that small hole, which is the orifice of the left main coronary artery, and mainly the cusps may bulge a little bit and make bulging on the anterior part of the left atrium. This is a full volume data set. And for identification of the different cusps, we do know the non-coronary is close to the interatrial septum, the right close to the right ventricle, and the remaining cusp is the left coronary cusps. Be aware of dropout artifacts and analyze also the commissures between the cusps. In case of a rheumatic aortic valve stenosis, we can nicely see the fusion and the calcification of the commissure between the non-coronary and the left coronary aortic cusps. With a different orientation during analysis, we can stop the image, and those markers point at the commissures, the interleaflet triangle, and the basal attachment point of the cusp. And the three basal attachment points forms the virtual basal ring that is accurately measured before TAVI. And with the help of this area and circumference measurement of the virtual basal ring, we select the proper device. So let's summarize the basic orientation rules. The aorticomitral continuities can be seen in the heart. The non-coronary cusp is always opposite to the atrial septum. The anterolateral commissure of the mitral valve is beneath the left atrial appendage, and the posterior medial commissure is close to the atrial septum. The left upper pulmonary vein is above the left atrial appendage and separated by a ridge. And the PFO and ASD2 are in the central part of the atrial septum. ESD1 is close to the AV valves, which are abnormally developed. The ESD sinus venosus type is associated with abnormally drained right upper pulmonary vein, and the right atrial appendage is separated from the superior vena cava by the crista terminalis. The coronary sinus is behind the left atrium, and its orifice is separated from the IVC by the Eustachian valves. Ventricle always keep their AV valves. In congenital anomalies, attachment of the tricuspid is shifted toward the apex. The perimembranosus inlet VSD is beneath the tricuspid. The outlet type is beneath the aortic valve, and the Gairbode type defect is close to the septum, causing left ventricle right atrial shunt. Imaging of the ventricular septum is very important, but beware of fast dropouts in case of tiny portions of the septum. Thank you for your attention.